this is me. My name is Hamid, like Dr. J introduced me, so kind. I'm a specialist here in Brazil and co-author of the double slot bracket. We have a ebook that we actually wrote that is called Innovative Concepts in Orthodontics. We have here the Sortec. It's a company, orthodontic company, that is the responsible for to sell this bracket and also to manufacture this bracket here in Brazil. I'm professor of postgraduate course in orthodontics here in an institution nearby. It's called Jae-bong. It's a few kilometers from my hometown. This is my contacts and my email. And I want to start, obviously, sharing this image that is it has a great value for me because it's the base of my life. So here we are with my family, my little daughter that has right now 2 years and 10 months. That's she called Pietra, and I have also 3 dogs that I love dogs. So what I'm doing right now here, it's basically it's because of her. So actually, all that I do right now, it's for my little child. Just let me do something here. I'm sorry. Okay. Okay. So, like I'm sorry here. Okay. Here are some photos of our students here in Brazil. We actually, this all are somehow working with us and get classes with us. We have not only students directly from Brazil, but from Peru also. We give to them a specialty course on orthodontics here. And this is some photos that we've made during those past years before all this pandemic thing. And I want to start saying that every time that I put this lecture, I give a few gifts for all the attendees. This is behalf of my group and on behalf of the WebCeph group, obviously. So at the end of the lecture, maybe today, maybe tomorrow, I swear to God that I will send you maybe later. But if you want to receive the ebook that we wrote, it's like a practice manual. It's very thin with a few questions, actually 30 or 33 questions and answers about how to use the double slot bracket with some images of the bracket and some images of clinical cases. So if you want to receive it, please send me an email. There is my email. Send me. Tell me where are you from, your name, and that you attend this exactly webinar, and I will send you with sure. Okay. So this is my gift for you guys. Actually, I will send also to Dr. J. So if he wants to share to other groups, that is fine by me. And I will start basically telling you for where I came from. So I'm from Venâncio Aires. It's a small city here in Brazil, actually on south in Brazil, in deep south of Brazil. It's a city that has 70,000 people here. And if you come to Brazil anytime, please send me a message. Maybe we can get along and meet personally. Like I told Jay before and all the panelists, I am like member of WebCeph, but I'm here. I wish someday I'll go to Korea and talk to him personally too. So if you come to Brazil, Brazil has great things here, great places. So I invited you, all of you, to come once and meet the Brazil as he really are, a beautiful country. And I want to start talking with you with the idea, why we have this idea, why we thought and tried to make something, well, let me put it this way, something kind of new. And I will start by quoting Albert Einstein that say, invention is not a product of logical thought. even though the final product is tied to a logical structure. So on the base of this quoting, I say that every time that we have an idea, we try to put a logical thought on it, because every idea that we make, we create, it's somehow attached to a logical thinking. So every time we develop things, it's tied basically to try to help someone in a logic way, like the proper WebCeph tool that was created to facilitate our life in order to try a better diagnose, or even to how to understand the diagnosis better. So this same invention or same creation of the WebCeph, it's tied to a logical thing. And so as the bracket that we developed here to try to help you. So I will separate the first moment of this webinar, trying to explain where came from the idea of the creation of the bracket. And here we have, I think, 3 great names among a lot of other names that we have in orthodontics, but I think 3 great names and 3 great moments on this first moment of the webinar. That is Dr. Engel, Steiner, and Dr. Andrews. And each one of them create something somehow to try to help us in orthodontics. So the first bracket that was developed by Dr. Engel, the father of orthodontics, it was the Edgeways bracket with a 22-inch slot to try to control in the 3 planes the tooth movement. A little bit longer of time, Dr. Steiner came with the idea, like Dr. Engel, but a little bit different, and reduced the size of the slot from 22 to an 18 slot. And this occurred because of the developing of the wires. So at the time Engel was working, the wire that was responsible to try to control and give torque, it was made by alloys of gold. So there is a large wire and has to be basically a 21 or 22 by 25 in order to control this torque at that time. But once we developed the wires, we start to work with SS wire, stainless steel arch wire. So at that time, it wasn't necessary to use the same wire that, the same size of wire that Engel started to use it. So at the time of Steiner, we could use maybe a reduced one, like a 18 per 25. So he thought, why we have to use at that moment a 22-inch slot? So he created the 18 slot bracket. And of course, I think we have a great gratitude to Dr. Andrews that start with the straight wire biomechanics, straight wire technique that put all the information that we need basically inside the bracket. So right now at that time, on the current of 60s, we got to start with a little bit less bends that we used to on a wedge-wise technique. Another and the second moment of this webinar that I work a lot and I love a lot, it's the bidimensional technique. And actually started the idea with Dr. Schutte, and was called the biometric system. And along of the way, we have a lot of orthodontists that developed the same idea, somehow a little bit different, like Dr. Gianelli, Dr. Rinchus, Dr. Epstein recently, and Dr. Celestino, each one of them working in order to use the bidimensional technique in the different ways, like Dr. Schutte twist the wire in order to get this difference of dimension between the anterior segment of the teeth and the posterior. Dr. Gianelli came with the idea to use a mixed brackets placing on the anterior teeth and on the back, as like Dr. Rinchus. Dr. Epstein and Dr. Celestino also work with that technique, and they came with the idea not only work with this different sizes, but using these different sizes inside the self-ligated slots, so in self-ligated systems. So actually the bidimensional technique, it came from the idea to use different sizes of a slot in order to try to control more earlier the torque on anterior teeth and get more sliding on the back. You'll see that This kind of technique, the bidimensional technique, it's normally used, one of the most kind of biomechanics, it's on sliding biomechanics. When we want to close a space, in that time you need so great amount of torque or great control of torque on anterior teeth and more sliding on the back. So by using these two kinds of different dimensions in the same patient, you will achieve the objective of the bidimensional technique. On the third moment, I will say, and I love to say that it's marvelous for me, working with two arch wires at the same time, as we call overlay or overarch, or two arch wires. And we call this kind of technique as piggyback technique. And it's very simple. The piggyback technique, the idea is to use two arch wires, either the same alloys or different alloys and different sizes, in somehow one arch wire. Normally a rectangular stainless steel arch wire will be used by anchoring the teeth and gave us stability on our teeth. And the other one, normally it's used a nickel titanium thermal activated wire, either rounded or either rectangular, in order to make the movement. So it's basically to place two arch wires at the same bracket, one to anchoring and one to move. And I love this because this technique is so simple and so easy to control and so predictable. Like it's a few predictable comparing to the other, but it's a great technique that I already used for during my whole life as orthodontist. And this is the image that we know about piggyback technique, or using of two arch wires at the same time. You see here that we are using basically one arch wire here to anchoring this tooth, and another one to make the movement to the buccal area of the laterals. So you have a stability control with that wire that is my 16x22 stainless steel, and this one normally could be, this is the 0.012, but you can use a 14, a 16. You'll see during the presentation that I'm going to show you. But it's a very simple way to put those two teeth in his right place. And here I brought to you an overview that was written by a lot of our authors, including Bert Melson, of a passive and active overlays. Like it's the same calling of the piggyback technique. And you see here that what was told, it's that a continuous arch wire system is simple to use and relatively comfortable for the patient, but is statistically indeterminate. Since the wire is inserted into a series of brackets, the forces generated by appliance and the forces resulting from a function and the muscular matrix are therefore unpredictable. So this is kind of when we use a straight wire or a continuous arch wire, actually not a straight wire, a continuous arch wire, it's so unpredictable and indeterminate because we have so many movements occurring at the same time that we cannot predict what is going to happen. And in the same article, a way to limit the side effect and thus improve the effectiveness of continuous arch wire system is to use two arch wires simultaneously. This is the piggyback technique. This approach is commonly referred as an overlay system or even overarch. A stiffer wire called the master is used to control the arch form, and highly elastic wire called the server to deliver the forces needed to, for tooth alignment. So basically the idea is to establish an anchoring, and the other one to move the tooth that you want. So it's so simple, and I am sure that a lot of you here, maybe all of you here, somehow use this kind of technique in one of your treatment in your private clinic. And the fourth moment, of course, and here we have basically, and recently during this past, I think 20 years, we have a great references and researches about the system of self-ligated bracket, like the passive and interactive one. So I love to use self-ligated bracket, not for everything that are told from them, but because it's more comfortable for me work with him by opening the clip and closing the clip. It seems more clear. It's more clean. The mechanic. So I use a lot of self-ligated systems in my patients, and I love it. But I also use conventional one. I actually choose the bracket from what the case needs, and I think all of us has to make this kind of thing and choices by using the right tools for the right service. That is the principal aim of our work here. So we have the passive system and the interactive system. So what do we think? Well, at that time, based on all of these ideas that was already created, not only by great authors, but other ones that I didn't quote here, we made some strategies. We make meetings and we try to think, how can we use all of this information in order to create something and put it all together and help everyone, or try to help everyone to make our treatment more easier, more comfortable, and more simplified. And well, we came of the idea with these two guys they were my professors, Dr. Shuni, Dr. Zuki, and on 2014, we achieved the patent of the double slot bracket. So this is a international patent of invention of a bracket. At that time, the first bracket that we create was this one, the self-ligated. So we took the idea of the passive system and the interactive system, and we put them in the same device with two slots. So here we have a double slot bracket with not one, but two slots, and each one of these slots has different self-ligated system. And the same idea we took to the conventional one. So on the conventional one, we took the idea of Engel and Steiner by using a 22 slot and 18 slot in the same device. So here you have not only one slot, but two open on the center of the device, and each one of this slot has different dimensions. So we have an 18 slot here, a 22 slot here. So this first bracket here that is called the DSL, basically it's a double slot self-ligated bracket. It was our first bracket that we developed, produced, and worked. And you'll see a bunch of cases. Actually, I put just 3 cases here, 3 or 4. I don't remember well, but I think it's 4. But you'll see 3 of the cases, they are made by use the self-ligated bracket because we work with this bracket during, I think, 5 or 6 years. After a while, we took out of the market, and so for now, this bracket doesn't exist anymore. The self-ligated doesn't exist because we took out of the market, and we are improving this device. We are getting better this device. So I think for the next year, we will have a new generation of double slot self-ligated bracket with a new design. So what we have today is the second generation of the double slot bracket that we call DSC, or double slot conventional. Okay, so this bracket here we produce, we work, and you'll see that everything that we've done with the self-ligated bracket can be done with the conventional one at the same way. Okay, the only difference is that this one has a clip and this one has to be used a elastomeric or a metallic ligature, but it's the same sequence. Okay, so here is the idea why this first generation has 2 slots, and the 2 slots are different system of self-ligated bracket. And basically the secret, it's on the clip. So you see here by the curve of the clip, you have one slot being a passive one and the other one it's interactive one. You'll see here basically what I'm saying. If you take this view here, okay, if you take this view here, you'll see that this clip has a curvature a little bit more deeper on this slot and a little bit more away from this slot. So this slot here, it's called the interactive slot, and this one is a passive slot, and this video will show you how it works. Once you use a rectangular arch wire on interactive slot, this arch wire will put a force to the clip, and he will move forward and the clip will respond back. But at the same time that you are using a rectangular arch wire on the under slot of this one here, you see that he will be always away from the clip. And even if he touches the clip, it's already on the maximum point of the deflection. So he will be not deflected by the force of the wire. And that's how we have two slots, each one of them with different self-ligated systems on the same device. So what are the options that we have when we talk about the self-ligated double slot bracket? So we can use and we can work only with interactive slots. So if you are a fan and you want to work only with the interactive slot during your whole treatment, you can use only one slot, the interactive one. And if you want to use only the passive slot, you already have on the same device the passive slot. So you can work with the passive slot. If you are love-it fan for the passive system, you can work during your whole treatment only by using the passive slot. So you can also choose the self-ligated system that the treatment requires. So we saw in a bunch of literature and researches that when we use self-ligated systems, they both have advantages and disadvantages over one and another. So someone called that we have to use the passive system on the first moment of our biomechanic, on the alignment and leveling, because he will not deliver so much force, and we have to use the interactive system to finish a case because obviously the force that the clip put on the wire in order to get better control of tipping and of course by torquing. So you can choose the self-ligated system that the treatment requires. You also can use, and here is the basic idea of this webinar, you can use the two slots at the same time. If you need, if you want, you can use it. So you can use the piggyback technique or whatever you want by using the two slots or two wires in independent slots. And something that I like too much is to vary the slots. So you can change the slots from one to another if you want to control vertical movements. I will show you that, okay? And the second generation, the DSC or conventional, as you want, we have actually on the same device two different slots. So we have an 18 by 30 on the cervical or gingival slot, and here we have on the incisor or occlusal slot a second slot that is 22 by 28. So we have the first bidimensional bracket on the market. So when we talk about bidimensional technique, when we talk about by doing kind of using the bidimensional technique in our patient, if we want to use that, we have to mix brackets. We have to buy an 18 sets of bracket and 22 sets of bracket, and we have to mix the brackets in order to put in the same patient. So if you are using the double slot bracket, it doesn't require that because you buy only one set of bracket and you use the slot that you want in order to get this bidimensional technique. This is a very good thing. Here in Brazil, we have some companies that work with sets of bidimensional brackets. So they send to you already along on the set, on the box, an 18 slot on the front teeth and a 22 slot on the posterior teeth, okay? So what is the options when we talk about the DSC or the conventional bracket? So you can work, if you like to work, as I love to work with the 18 slot, you can work only during your whole treatment using the 18 slot. So you don't have to use the 22. Forget it, the 22. Use only the 18 slot because it's there. You can use it only this slot. But you can use also only the 22 slot if you are a fan for the 22 slot. So you can work during your whole treatment making your whole sequence of arches using the 22-inch slot. You can use the bidimensional technique by using either the anterior, on the anterior teeth, the 18 slot on this bracket, and on the back, you can use the 22-inch slot on the same bracket. So you can do this playing by making changes either on your arch wire or either on your placement of these devices. You can also use the two slots at the same time. So you have two slots, open slots, very easy, and you can use them. And you obviously can vary the slots if you need some vertical movements. So when we talk about biomechanics, actually, there's a bunch of things that we have to understand in order to all the pieces fit each other. Of course, we are not working on a machine. We are working on a human body with a person. So basically, when it comes up and we talk about biomechanics, there is a lot of words that came up to our mind. And this kind of words, there are some words that we have to think of in order to get a successful kind of results in biomechanics. So we're talking about direction, force, vector, physics, tipping, determinant, center of resistance, anchorage. So this is a few questions or a few words that we have to think of when we talk about biomechanics. That is it. So basically, I always say that when we talk about biomechanics, I think it's the most simple kind of thing in orthodontics. I think obviously the worst thing, or even the hard thing, not is the worst thing, the hard thing on orthodontics, basically it's first diagnosed, that is the principle of orthodontics, second plan of treatment, and on third place biomechanics. So you have to make a good diagnose, a great plan of treatment. That if you do this good diagnose, you will make the great, basically your good plan of treatment, and then you will execute by using your kind of biomechanic that you want, and you will choose the tools that you want. So this is up on you. And when we talk about biomechanics, there is a word that we have to understand, that is control. So every time regarding the biomechanic that we will have, there is something in our mind that has to be aware, control. So we have to control the anchorage, the tooth or teeth movement, the friction, and the force. If you have these four principles in your mind, if you think about these four principles in your mind, controlling anchorage, controlling tooth or teeth movement, controlling your friction, and controlling your force, you basically will control everything in your biomechanic. And in order to get this kind of control, you have to use anything at your disposal. And we have everything in our disposal in order to make biomechanics. We have aligners, we have mini screw, we have mini plates, we have a bunch of wires, we have a lot of diversity of brackets. So we can do everything in our hands to make successful and great results biomechanics in our treatment. So I always say that when we talk about biomechanics, we are talking, I think there is no better word to describe what we do in orthodontics. Biomechanics, we are working in a biological system doing mechanics, applying physics. So if we split these two words, we will have the actual mean of this word. It's bio and mechanics. So biological system, and mechanics, physics. So we apply physics on a biological system. Okay, so I'm going to start with some cases right now. I want to remember you guys that most of those cases were made by using the double slot self-ligated bracket. This bracket doesn't have on the market. I know that they will answer me a lot of things of this bracket. I can answer you, but this bracket will return on the market on the next year, okay? And I have one case with the double slot conventional bracket, and I will tell you why we have just one case right now, and he's not finished yet. But it's the same way the thinking, it's the same sequence of arch wires, the same thoughts, it's the same everything by using these two different brackets in your treatment, either the self-ligated one or the conventional one. So the first case that I want to show you, it's a molar intrusion. So what we have here is a patient that have a great alignment, a great leveling, and she had extruded she had the 16 extruded here. So in order to put something below, like an implant, we have to take this molar to his right position in order to get a sufficient interocclusal space. So here we have the occlusal plane, and you see that not a great extrusion, but it's a bit of difficult kind of work with the interspatial occlusal. Okay, so in order to intrude a molar, we can use a lot of things, including the mini screw. That is one of the tools that I most like to use in my orthodontic practice. And you see here that we have different kind of ways to work with mini screw. The first one is by using 2 mini screws on the buccal area and 1 on the palatal area, and by using either coil springs or elastic chains, we can intrude only the molar. So we can do a point mechanic. So if we need to use mini screw, maybe we don't have to use any fixed appliance. We can use only the mini screw and treat the patient without anything else. This is a different kind of using the mini screw that you already know, by using 2 mini screws in diagonal between each other when we put in a buccal area 1 and on the palatal area the second one, and by using the elastic chains, we also will get the delivery response of this intrusion of molars. Okay, but if we are using somehow only fixed appliance, let me think that the patient doesn't want to use mini screw. I don't know, she doesn't want, or the orthodontist doesn't know how to use, or we don't have some space between roots to use, or the height of the mini screw will be so under that we cannot put. So we have a lot of things that we have to understand in order to put mini screws. So the mini screws is the best anchorage ever. You know, it's so simple to use. The technique is simple, but somehow there is difficulties that we are going to find when we use mini screws. So one of the problems about the mini screws is the hygiene from the patient. If the patient doesn't hygiene well the area of the mini screw, he will fail. There are other advantages, like if you don't have spaces enough between the roots, or either if you cannot take back the muscles of the patient in order to get a clear vision to do the mini screw. So I think there is a few advantages, not so much, but a few ones that requires that we have a plan B in our hands. So the plan B here, it's by using 2 arch wires. You're seeing here that I'm using a continuous arch wire, something that we never have to do. We never should do. You never should to use a continuous arch wire when you have obviously a extruded molar. So what we do if we want to use 2 arch wires at the same time and get this molar intruded? So it's very simple. We use a rectangular arch wires that will be the 17x25 SS, and a round arch wire, more flexible, that will be my 90 thermal activated arch wire, in order to intrude. So at that point, you have not only your anchorage system established by the 17x25, that is a great arch wire in order to get this anchorage unit, and you have a force given you by the rounded thermal arch wire. So it's like this. You have here the bracket on the profile here, and you see the 2 wires inside the same slot, and you see the first problem is the high friction that we have along with them, because they are in contact with each other. So this is the first problem when we use 2 arch wires in the same slot. Okay, obviously in that kind of work here, intruding molar, it doesn't matter for us, because the friction that we have here by using the 2 arch wires at the same time, it's not so big, because what we have, it's at the point at the molar get intruded, the wire will slide to the back. But in cases that you'll see that we need some sliding of the wire inside the slot, it's worst if you have two arch wires in contact with each other, okay? So if you're using this kind of way, you will get the 17 per 25 and the 14, and what you're going to have is basically this kind of result, the intrusion of the molar and no response back or no undesirable movement on the adjacent teeth. But once you get your movement, you have to change your 14 for the 16 thermoactivated arch wire, because that 14 doesn't have more potential. So what is going to happen basically that these two arch wire will not fit inside the same slot, because geometrically they doesn't fit. They are too large and there's too small space for them. So what we have to do is change one of the wires. Normally, because we have to use the 16 thermoactivated, we change the 17 per 25. So we have to reduce our anchorage wire. And normally what the orthodontics do is putting two round arch wires inside the same slot. In that case, you'll see an 18 SS and then 16. Well, the problem is that the best anchorage arch wire in order to use with an overlay technique is the 17 per 25 when you're doing the intrusion, because the intrusion is the most difficult, one of the most difficult movements on our treatment. It's an unphysiological movement. We have to put the tooth inside the bone and not outside. So if you don't establish a good anchorage, you'll lose your anchorage. Maybe you'll open your patient's bite, or you're going to increase a little bit the vertical dimension of the patient, and so many problems often and often, okay? So what happens here is that because we don't have a space, we put a thinner arch wire, and it's going to have is the extrusion of the adjacent teeth, okay? But if you're using double slot bracket, it's a little bit more simple in my view, because once you have two arch wires, two slots, you can use one slot to each arch wire that you have to use in this kind of treatment. So it's the same principle. We are using the same wires, but now in two different slots. So it's the 17 per 25, SS, and the 14. So as long as we will changing the wire and getting the movement, you see here on the right side on the screen that we have here the 17 per 25 and here the 14. And once you have to change your 14 for a 16, we do that. So it's very simple. It's just to take out and put other back on the place. So you have the slot open to you. Do that kind of thing. So it's so simple. You don't have to worry to reduce your 17 per 25 because he's on another slot. So you maintain your 17 per 25 during your whole biomechanic from the start to the finish. Okay, so we took the 14 out, we put the 16, we get a little bit more intrusion. Once you get a little bit more, if you need other arch wire, we'll use either if you use a 16 per 22. So you can use two rectangular arch wires at the same time. You see here that I'm using a 16 per 22 here and a 17 per 25 there. So you finish your intrusion. So here is the case. The patient already has a great leveling and alignment, so we just have to align a little bit back. You see that I didn't include the molar because I don't want to put anything on it before I establish a anchorage unity, okay? And here is a quick tip for you guys. You see here that I use the second molar in order to pass the tube, and I know that a lot of you use second molars. I myself love to use second molars. I think that is a great thing when you use second molars in our biomechanics in whatever biomechanic that we are working on. But I think when you use, it gives you a little bit more practice on your treatment. So a quick tip for you guys, if you want to use the second molars, we know that the second molars, it's a little bit different comparing to the other tooth because he has a distal angulation of the crown and a mesial angulation of the root. So he's like this. And if you correct this kind of angulation, he may extrude and increase the vertical dimension of our patient. So the first quick tip here is to use the second molar normally passive to the other teeth. So you are seeing here that this wire here, it doesn't have any deflection. So he's passing passive through this premolar to this molar. The second tip is the right tools to the right job. So I use a lot this clamp, curve clamp here, and this retractor that is a Minnesota retractor that we use in surgery. I use this in order to get more vision of the tooth that I'm going to bond. So if you use this kind of retractor, you will take a good view of your two teeth. And with this clamp, the curve clamp here, you can put from the front to the back in this way, and it will be so simple to start to place tubes on your second molars. Okay, so this is the quick tip. And once you have all the alignment established, once you have basically your anchorage system established, I will put here, you'll see the 17/25, and here I'm using the 14. So I have two arch wires, one rectangular, one SS, and the other one thermoactivated, one rounded, and they are in two separate slots. So here I have establishing my anchorage, here I have the movement control, and here I have the next photos. You see here that from 1 month to another one, I just change actually the wire. So you see here that this wire were in this the occlusal or the gingival slot. In the meanwhile, this one is on the incisal or occlusal slot. But once the patient get back to my private clinic, I saw that the molar has intruded a little bit, and this wire was passive. So it didn't get force. We didn't have potential force. And either if I change for a 16 or either if I put a 16/22, it doesn't matter because the wire will be continuous passing through the first molar to the second molar in a passive way, so it will not intrude. So once you get, and when I told you that we can variate the slot, this is what I'm talking about. You can variate from here. So I change the place of this wire that were here and I place under it. And this wire that were here, I put over it. So I change the two slots, the wires from the two slots. And once I did that, I get more potential of the wire. So this is the same arch wire. This is the same arch wire here and here. The only difference is because I changed the slot, I get a little bit of deflection. This deflection made the force that I need to continue get the intrusion. So at the end of 4 months, I got the intrusion like this, as you see here, by using at the final arch wire is 16 thermoactivated. After that, the only thing that you have to do is take out the two arch wires and continue your sequence of arches to the end, okay? So this is the result of 4 months of a simple and comfortable kind of technique with two arch wires. We achieve basically the anchorage by using a 17/25. The tooth movement we control since the beginning. The friction actually here doesn't matter because the friction was related to the tube on the back, but on this next case, you'll see that the friction is very important. And the force, the very important thing here is the force. And the force were delivered by a nickel titanium thermal activated wire. That is a wire that gives me a constant and gradative force. That is a very important thing. So it's a physiological force, and we get this by using a nickel titanium thermal arch wire, okay? So one question that always came when I show this case, it's because we are working far from the center of resistance of the tooth, and we do this kind of movement. Normally, he get this kind of placing to the buccal area. And this obviously right because we are working on the crown and the center of resistance is far from the force applying of the wire. So if you are making this kind of working with two arch wires and you get this kind of movement to the buccal area, you have two ways to get out from this and correct this position. One, it's by using, and you saw that I use a edgewise tube. I use edgewise tubes on my cases. Some cases I use prescripted tube, but in this one I use a edgewise tube. But it was more easier for me if I use a prescripted bracket, prescriptive tube. So if you see here, if you get this kind of movement, you can replace your tube to another one, to a Roth prescription or Andrews prescription, or either a MBT prescription, because once you fill the slot, he will correct automatically. And the second way to do that, it's by giving a manual torque. So you twist the wire, and once you gave a proper torque, in this case a negative torque, a palatal torque, he will back to his right place. Okay, so this is how we finish our case if we have this kind of movement. The second clinical case, it's by a girl that came up to my office because she had a impacted canine that it is here. And the first tip that I give to you is, please don't do traction of canine only by using radiographies. Please take CBTC, because here you see on the x-ray here that I have two-dimensional view, but I don't have the relationship between the crown of the canine and the root of the other tooth. So once you get the CBCT, you take the three-dimensional vision that will give you more security to use in your treatment. So here is the CBCT. Here is basically the kind of way what used to kind of happen when we have a impacted canine in this area. So first, obviously, we align, we level, then we take out for the surgery, we request the placing of a device over this canine. So once it's ready, we can start basically doing our movement. So if we have this kind of impacted canine in this region, basically on the palatal area, first thing we have to take out is this kind of thing. You see here that we have a relationship between the root of the lateral and the crown of the canine. So normally, sometimes we cannot put the canine directly to his place, because we will assume the risk that he will resorb the lateral root. So the first thing that we have to do normally, it's get the canine back and then replace directly for his right place. So this is kind of the technique that we do in this kind of cases. Okay, so I start by aligning and leveling, and you see here a open coil spring that have no force on it. It's just to maintain the space between the lateral and the premolar in order to maintain this space. And here is the alignment of the patient. Once I have all the tooth aligned, everything good, I will put my anchorage stability arch wire and the second one that will start my traction of canine. So you see here, after a time that we bond surgically the device, I start to use a 16 wire that is a thermal one, tracting this canine, and the second wire here that you see here on the lateral photo is a 17/25. And why I place directly the wire and I'm getting to his right place, because he's far from the lateral root. You see here that here is his crown, and if he were here, I would take care. But because he's here, I don't have to be so secure, because he's already in his right place. I just have to bring it home. Okay, so and one important thing that we have to get in our mind is this thing. We don't have to make some great deflection. Please don't make great deflection with your wires. Like I told you, we are working in a biological system, applying force. And in order to move tooth that is surrounded by a lot of things, bone cells and everything, we have to try to put the optimal force or even the biological force. And how I measure that? Well, there is a lot of things that we could use to measure force, but I look vision. So as much I deflect the wire, the thermal activated, I assume that is more force on my system. So not big deflection, but small deflection in order to get forces, level forces good, okay? And another thing that is important, as much you deflect your wire, more you are creating bindings and notchings, and you are creating friction here and here. So every time you create a great deflection, you may create more friction on your system. And this is the biomechanics that require a little bit less friction, because once you deflect the wire, as the canine goes to his right place, the wire will get back and he has to slide. So in order to slide, he has to get less friction. So you're seeing here that once the canine came over his kind of right place, I put a bracket, and once I do that, I couldn't use a continuous arch wire because this stainless steel rectangular arch wire will contact the canine. So you have two options. The first one is pass your 17.25 here, make a bend here, another here, and here, like a bypass, or like I did here, you can segment those areas. So I segmented here the wire and here. So I have two pieces of the 17.25, one from the lateral to the first molar and the other one from the premolar to the second molar. So I have two kinds of stability units, and the 16 passing through the canine. So here I go, is just changing wires, and the only wire that will change on this moment is the rounded thermoactivated arch wire, okay? Here, he is already almost in his right place. You see here that's a little bit rotated. You also see here that we have a little bit of diastema. This is so easy to close just with elastic chains. So after a while, if you have this kind of scene, it's just aligning a level and leveling and just finish your case. Once you have all good, take your panoramics, see if they are parallel between each other, and you can take out your braces. So this is the case finish, okay? And something very important that you see later, I use here a fixed retainer because she had a little bit diastemas, and in order to not get back those teeth and open this diastema, I put the fixed retainer here on the upper arch and on the lower arch, okay? So here she is on her first photo. She is on his actual photo. He's a beautiful smiling, beautiful girl. And once more, I think we achieve everything that we talk about it, about principles like anchorage, tooth and teeth movement, friction and force. And once one of the things that I want to take of you, it's this four kind of principle, the force, because you saw that as long as I control the deflection, I will deliver level forces that are so small, so biologically, that at the end of your treatment, on this kind of treatment, you see that when you make in this one where the canine that are attracted, and you see this part here and this part here, and aesthetically they are like the same. So this were possible because I used higher level forces that were optional, okay, or either biological. So once you do with higher forces, what you're going to do is extrude or tract only the canine, and the bone and the periodontal, the PDL, they all will be left on there, and the canine will come to his place, but only the canine. It's basically you are tracting the tooth along, not with all the parts that surround all the dental alveolar complex. So if you are doing with the right forces, what you have is not only the success, but the aesthetic that you need, that is this one. So if you see here and here, there is no difference between the two canines because we use the level of force that is right, okay? I'll be very quick right now because I see that the timing is going. This is another case of traction, but I told you that I'm going to show you two cases. And one of them, it's with a conventional bracket. So it's like the same, the other one, but the only difference here, I want to show you the difference between the self-ligated and the conventional one. And here is it. So you have here the Cbct showing you the position of those canines. You have here basically the spaces that we have on diastemes, and we can use open coil springs to close a little bit and open the space here and here. And well, the sequence is like, obviously, we do the alignment, we do the leveling, we get the master or the anchorage arch wire, that is our 17/25. This photo is changed. So, and we start to traction. So you see here that on this case, I am just getting the canine to his right place. But this one is so near to the root of the lateral, so I use an elastic chain to put him back and then to put him on his right place. So this is the difference between that bracket and this one. So here I have the 18 slot here, this 22 slot here, and I use a elastomeric ligature. And I am using 2 arch wires, okay? So I'm doing the right job here by establishing the anchorage by this arch wire, and I'm doing my job with this one that is 16 thermoactivated arch wire. And you see here, this is were made by Zuki, one of the colleagues that create along with us the bracket. And you see that the same philosophy that we have, we use less deflection ever. So small deflection means better forces. I'm going to get the sequences because it's very similar one of each other. But this photo, I want to emphasize a little bit. You saw that we used during our whole treatment from the beginning to this part, every time, obviously, we had to use a elastomeric ligature to fit these 2 arch wires inside the slot. But you see here that on the premolars, he used basically metallic ligature. And that's why, because as long we put the deflection on the arch wire in order to track the canine, once the arch wire goes back to the normal form that he have, the wire has to slide here. So in order to slide, we have to create possibilities, and the possibility here is less friction. So what you're seeing here, here is the 2 cases that I showed you. This one is the first one with the self-ligated bracket, and this one is what I'm showing you right now. And the only difference between these 2 cases is that when you have to manage your friction with a conventional bracket, you have to use metallic ligature. That is the only thing, the only difference. But the wire is the same here, the anchorage wire is the same, the nickel titanium is the same, it's the same like this. The only difference is because I have here a self-ligated bracket, I don't have to worry with friction. But here, if I used here a elastomeric ligature, it will be a little bit more difficult to this arch wire slide to the back. So I changed the ligature and I put a metallic one, and this one I manage the friction. And what you're seeing here, it's the first photo and the second one before he get back the elastics. And you see here that is the wire he cut here, and 1 month later the wire is a little bit slide to the back. So this is managing and control of friction. So the case, it's being on treatment right now. He didn't finish yet because he will finish, I think, in a few months. But you see that from one side, the canine is already on his place. The second one, he starts attracting to his right place too. And this is the sequence. So he starts to use here the bracket. So it's a very simple. Once the canine goes to his place, the only thing we have to do is take out the 2 arch wires and make all the treatment like 1 arch wire only by aligning and leveling and finishing. And the last case that I want to show you, it's a big case that I done here in my private clinic, that the patient has a bad occlusion here. You see that she have a great protrusion of the anterior teeth, a big protrusion and proclination. And actually, this is not her bite. It's wrong. She couldn't bite right. So I put the models up with each other, and you see the big overjet that she have. You see that she has almost 100% of class 2 canines. So the order here was to extract the 2 premolars, and the other thing that you see here that she have these 4 lower incisors extruded. And so the actual plan was to extract 2 premolars, retract all the anterior, and correct the torque of the anterior segments of the upper arch. And on the lower arch, we have to intrude these 4 lower incisors. This is the plan of treatment, okay? So we extract And normally when I have to extract, I extract before I place the brackets. It's a policy on my private clinic, 99% of the cases. Okay, so here it is. I start by placing the bracket, the self-ligated double slot bracket on the upper and lower, and you see that I didn't pass anything. I didn't place nothing here because I don't want to change nothing here. I just want to establish the anchorage, and once I have established the anchorage here, I will start my biomechanic by intruding these 4 lower incisors. And on the upper, I will make the retraction. So what you're seeing here is the sequence of photos with different arches at the same moment. So here I have a little bit of sliding to the back. You see here that I have this excess of wire, okay, that proves that I'm retracting those, or maybe correcting a little bit more the torquing by turning a little bit more vertical and to the back. And when I have the 17/25, as I told you, not even has to be always the 17/25, but in cases that I use like molars intrusion or 4 lower incisors, it's better as more stiffer your arch, it's better for your anchorage system. Okay, so I start here by using the 17/25, and I start to use here a 12 nickel titanium thermal activated. Why a 12 and not a 14 or 16? Because we are working with 4 lower incisors that are so thin, and the average and the rate of root resorption is so big, so we have to get more careful about the force. Okay, so I used a thinner arch wire here to start my intrusion. On the upper, I'm retracting. Okay, and one thing that is very important, you see here, this is how we manage force with the double slot bracket. You see here that I'm using, let me see this photo. You see here, guys, that I'm using at this photo here, I'm going to show you a little bit just the sequence here I have using, and you see that it's better the upper, and the lower, it's shown the bracket itself, but here it's a lateral photo. You see that we almost got we have like 50% of class 2 here. We already get 50% less than we start. Okay, and how I manage this force, when I talk to you about managing force or control force, this is how. You see here that I start my my intrusion by using this wire here, getting out from this slot and entering on this slot. And you see that I already have a free slot here also. But why I didn't put this wire here? Because I don't want to create so great deflection. So I pass through the one slot that is more above, and I put in the lower slot on the incisors. So I already have here free for me to use another slot. So if I want, and I did that, you see that this wire is passive. There is no force on it. So what do we have to do? Get a little bit above. So you get a little bit more deflection and a little bit more potential. So what I've done here is I change only the wire from these 4 brackets. I pass from here to the upper slot. And once you pass, you create a little bit more force. Okay? And I continue making the intrusion and the retraction and correcting the torque on the anterior upper teeth. Here you see that it's a little bit better, the intrusion. Okay? Almost closing the spaces just a bit here. And the problem on this patient that she got to be pregnant, and I have to get a little bit hurry with her. She wants to remove the device. So I asked her to make a new documentation in order to compare one another. And she made that with the bracket at the time. And once she made it, we removed the appliance. And here is the result. So here is the initial photo of the intrusion. Okay, first and at basically the end. This is the moment that I asked her to make the new documentation, because she, like I told you, she wants to be pregnant and all this stuff. So I got to be hurry because, or I will miss this the images. And I'm sorry, here is the photo. Because all of this situation, she asked me to take out the braces, so I took out. It could be a little bit more finishing with excellency, but comparing one photo to another, I think we achieve a great result. The patient was very happy. We intrude the anterior lower incisors. We retract the upper anterior teeth. And because she has a problem with a 2K here, I just put a resin here, and I just maintain this space in order to make after the time the restoration. Okay, so this was at the same moment that I took out the braces. So I'm sorry for the quality of the photos, but I think if I did not get this photo, I will miss this case forever, and I could not miss. So this is the photos. This is the radiographies that shows that at that time didn't occur nothing of resorption. This is the Ceph that comparing. I think I'm going to put these two cases on WebCeph software and try to compare one and another Cephs. Okay, but you see that it's a huge difference. Basically didn't turn a lot. Her profile to improve a little bit. Okay, as I told you, she made those photos with the fixed appliance. And by finishing, guys, I want to say a few words. I think that the double slot bracket opened a new door for us in kind of terms of biomechanics. So I just think that we we just get only for the surface. We just reach the surface of the things that we could do with double slot bracket, in my opinion. I don't know if there is a lot of things or no, but I think there is a lot of kind of things that we can do with the double slot bracket. So we have a lot of doubts. I talked to a lot of guys that call me after the webinars and ask me a lot of things, either on the webinars they ask me, and we have our own questions. Like I have doubts of my own that we have to respond in order to get more clarifying and proper answers to work with the double slot bracket. But all that we have is clinical. We don't have anything by researching. We have one or other article with clinical case and presenting the bracket, but in terms of comparison of one bracket and double slot bracket, we don't have. So the questions that we have, like I made these questions of myself. Oh, I'm sorry. So let me do this because it's not right. This is wrong. I wanted to put here and here. Okay, now it's good. So one of the questions that I have on my own, it's we have a better control of tipping by using 2 arch wires and 2 different slots compared to 1 arch wire and 1 slot. I don't know. By logic, yes, because when you have this kind of thing here, when you have this, you create just 2 points of contact here and here to manage or to control or to make your tipping. When you create 4 points by using 2 arch wires and different slots, I think it's a better control of tipping, but it's only by logic that I can respond that. We don't have scientific studies, okay? So by torquing, it's better, it's not. By using 2 arch wires, can you control better your torque if you use 2 rectangular arch wires on the different and double slot bracket comparing to this kind of thing? I don't know. Actually, I don't use 2 rectangular arch wires in my cases to finish. I just use 1. So I just use 2 arch wires when I need to do some biomechanic, or so if I can, I have to rotate some tools, something like that. But in normally things, I just use 1 arch wire. So to finish, I use 1 arch wire. I didn't use 2 arch wires at the same time to try to better torque. So, but there could be more control of torque. I don't know. About friction, can we assume that when you use 2 arch wires inside the same slot, we have more friction comparing to 2 arch wires to 2 different slots? By logic, yes. If we see this image here, we assume that it has more friction when comparing to that, but I don't know scientifically is this different, is statistically or not determinant to the case. So this all are questions that I have, and we have to respond that. And I have a great a great happiness that I am. They are searching me, colleagues that want to try to use the double slot bracket to make those research. So I received yesterday a call for a guy that told me, listen, I want to see how it works with double slot bracket. I want to test it. I want to make researches. I have guys from Philippines that are making some thesis of mastering of their mastering on the postgraduate school, and they want to use the double slot bracket to make some experiments and see some ideas if there is different comparing the double slot bracket to the other bracket. So it's very good for us because we have to get those answers as soon as we can. But by summarizing, what I have to talk with you guys is that you can work with the double slot bracket, and I'm talking about the conventional one right now, not the self-ligated. You can work either with an 18 slot or 22 as you need or as you want. You can use the bidimensional technique by using just one bracket. You don't have to buy two sets of brackets. You don't have to mix bracket and all this stuff, okay? You can work with segmental or continuous or the both in independent slots. So you see that you can not only work with continuous arch wire, you can use segmental arch wire, you can use one segmental, one continuous, you can use power arms, you can use cantilevers in independent slots. So it's something that you can explore as you think and you create something on your biomechanics. You can use two arch wires, obviously, at the same time in different slots. I think you have less friction by using two arch wires in different slot when comparing to one slot bracket and two arch wires in the same slot. Like I showed you on the photos, you can vary the slot so you can make more potential or less potential of intrusion or vertical movement when you just put from one slot to one tooth to other one. So this variation of slot could make you a new kind of movement. Either we can interscopate with this variation, okay? You can reduce or avoid the needs. This is very important because you saw that in my whole biomechanic, I didn't use nothing but two arch wires and the double slot bracket. I didn't use a transpalatal arch. I didn't use nothing, mini screw, nothing, just two arch wires. So I'm not against of all this stuff, but as less we use, better for us and our patient. I think that I think so. So think on you. It's better you use a mini screw or if you could use some biomechanic without the mini screws, could you use that on your patient? I'm not talking by not to use mini screw. Actually, I will tell you, use mini screw along with the double slot bracket. I think you will have the both of two words. You have on the one side, one bracket that offers you a new kind of possibilities, and the other way you have a mini screw that is the best anchorage ever. But if you put them together, I think it's unbeatable, okay? This is my thinking, okay? So, but if you can reduce or minimize, it's better. I think the mechanics become more simplified. You saw that only what we have to do is basically align and get a stiffer wire and use a second one in different slots, and that is it. Each kind of movement have their principles. Okay, it's more comfortable biomechanics, and you have a great diversity of arch wires because when you use two arch wires at the same slot, you are limited by the numbers of arch wires that you can use in the same slot. But once you have two slots, you can use whatever you want, any alloy, any number of any size of arch wire at the same time. So we don't have the key of all those answers. We're just exploring that along with you, and I ask your help to help us to get more answers and questions about the double slot bracket in order that we answer them or you answer them. So it's like a puzzle. We are searching in order to try to see the right pieces to fit each other. And I will end by quoting two great minds of the world. One is obviously Leonardo da Vinci, that it calls simplicity is the ultimate sophistication. This phrase, this quoting fit good for me. So be simple, be simple. As simple as you are is better, as less as more. I think that way, okay? And by Albert Einstein, saying everything should be made as simple as possible, but not simpler. So what I'm trying to do here is simplifying the thing for you. Okay, I'm trying that. So I don't know if there is, I achieved that point of goal. So think out of the box, guys. This is my my contacts, my emails, okay, Instagram, Facebook, my WhatsApp, my email here. I'm almost 24/7. Jay knows we have a difference of timing here and from Korea, like almost 12 hours. So right now it's 10 and almost 10 and a half a.m. But normally I talk to the people around the world at different times. It's an issue. So I'm used to get awake 1, 2, 3 a.m. on the morning. So if you need something, any doubt, be my guest. I will be able, of course, to help you guys. Don't forget to smile. So I want to thank you, all of you guys. Thank you, WebCeph. Thank you, Jay. Thank you, guys that get here and spend a little bit of your valued time with me to hear about double slot bracket. I hope you enjoy it. So I open to the questions.